Strength training and heart failure, Savage et al. This is an important topic. If you train any older clients at all, I'll bet Andy, where's Andy? I'll bet Andy has at least one guy in his client pool who has heart failure and doesn't know it. I'll bet he has at least one guy like that. Heart failure is huge in industrialized countries. It is huge. It is a major contributor to adult morbidity and mortality and quality of life. What is heart failure? It's often called congestive heart failure or CHF. I've got a guy at my shop who's a little bit of a pedantic prick, and he does research in heart. He's actually a brilliant guy and a nice guy. He does research in heart failure. NIH-funded research in heart failure. He's like, no, you can't call it CHF anymore because it's not all congestive heart failure. And I'm like, Phil, it's all chronic heart failure. So I'm still going to call it CHF. It's chronic heart failure. Yeah, don't look at me like that, right? What is it? The heart can't pump hard enough. That's the poor man's way of putting it. The heart just can't pump hard enough to meet the demands of the circulation. It can't meet the afterload that it sees when the aortic valve, or in the case of the right heart, the pulmonic valve opens. It just can't squat that weight. It's just not strong enough anymore. The ejection fraction is insufficient to meet demand. What do I mean by the ejection fraction? Because it's an important parameter. The ejection fraction is the fraction of blood that is ejected by the ventricle. The fraction of blood at the end of filling that is ejected by the ventricle. So during diastole, the heart relaxes, the ventricle fills. How much of that blood is ejected in systole? That is the ejection fraction, and the normal value is? Normal ejection fraction. Yeah, about 45 to 55%. In my population, the normal ejection fraction is 30%. Leads to exercise intolerance, weakness, dyspnea, multi-organ system failure, progressive cardiac structural remodeling, arrhythmia, and death. And that's how most people die with congestive heart failure. They don't just congestive heart failure to death, right? The heart gets all stretched out and deformed, which means that the electrical conduction system inside the heart gets stretched out and deformed, and then one day you just go into VFib and die, right? Or VTAC and die. You drop dead. That's how, which is merciful, considering the alternative way of dying, which is in cardiogenic shock and pulmonary edema. The 5-year mortality sucks. I think I've said in this venue before, if somebody offers you the choice between CHF, symptomatic CHF, and a generic cancer, take cancer. You'll live longer and you'll probably have a better quality of life. It's a horrible disease, and it is epidemic in adult populations in industrialized countries. This is what's going on, right? So the heart is bigger. The heart got huge. It's got gains, right? But it's actually weaker. It's like a bodybuilder. It's bigger, but it's weaker, right? It just can't pump as hard, right? And it gets stretched out and it gets deformed. Now, the histological correlate of this is exactly like in the sarcomere. You know, when you stretch out the sarcomere, right, the muscle is able to contract harder because of that. So this is early on, this is an adaptive response. The heart is like, well, I can't meet the load, so I'm just going to stretch out a little harder so I get more of a bounce out of the hole and I can pump harder. But that eventually becomes maladaptive and the heart starts to fall off that curve, right? So initially what happens is when you have an increase in end diastolic volume, the heart stretches more, accepts more volume, it's able to increase its stroke volume, its ejection fraction, and pump harder. But eventually, over time, it falls off that curve, and the histological correlate of that is that the actin and myosin filaments have reached the end, the cardiac sarcomere has reached the end of its functional extensibility and gone beyond it, right? So that's not good cardiac remodeling. Whoop. And so you start to get these curves that become progressively more dysfunctional. So big increases in volume don't lead to a corresponding increase in stroke volume, and the heart fails. And where does that get you? That gets you from this guy. This is a normal chest x-ray, right? As my friend Scott likes to say, 1 heart, 2 lungs. This medicine shit's easy, right? Normal sized heart. Nice translucent, radiolucent lungs, right? Nice dry lungs. You can see the pulmonary arteries here. That's the fluid density, right? And then you get some guy who comes into my ER like this. Giant congested heart, lungs full of, this person is drowning in their own fluid.
How big is the heart in that image?
Here's the right cardiac border, and I think the left cardiac border is right about there.
Wow.
Yeah. And all of this is fluid in the alveolar spaces. In the gas exchange, this person is literally drowning. This is what we call pulmonary edema. It's one of the end-stage presentations of congestive heart failure. And if you don't do something in the next 20 minutes, this person's going to die. So what do these guys do? Most studies of exercise medicine and heart failure, and there are a lot of them, right? Once we got over the idea that if you exercise people with heart failure, they're going to go into an arrhythmia and die immediately, once we realized that that wasn't true and that these people responded to exercise medicine with improved function and quality of life, this area of research took off, in part because this is such an important clinical entity. My colleague, who I mentioned earlier, has shown that if you look at people with asymptomatic hypertension, especially in an inner city African American population, you'll find that a significant percentage of those people actually have undiagnosed heart failure. Right? So a lot of people who have heart failure don't even know it yet. Most of these studies don't look at a lot of patient-oriented outcomes. A lot of them like to look only at walking, you know. How far can you walk in 6 minutes before you get short of breath and you have to stop? The authors point out that aerobic capacity is a poor correlate of activities of daily living. Wow, somebody actually acknowledged that in the biomedical literature. Right? That was worth the price of admission right there, and most of which are not primarily aerobic in nature. Their hypothesis is that CHF patients are characterized by high levels of physical disability, correlated with both diminished aerobic capacity and muscle strength. And they hypothesize that resistance training and increased strength will increase the ability to perform activities of daily living independent of any improvement in aerobic capacity, by which they mean VO2 max, or in this case, VO2 peak. What is the difference between VO2 max and VO2 peak? VO2 max is the point at which you have a plateau of oxygen uptake over time, right? And what is that plateau of your maximum oxygen uptake over some period of time? You can't do that with CHF patients. They can't do anything for any period of time, right? So you measure just how high did they get? Not how high did they stay, but how high did they get? What was their VO2 peak? That was what they used for aerobic capacity. They also did a test of aerobic performance, and we'll talk about that in a minute. Experimental group, 13 CHF patients, 10 completed the study. It was not what we call an intention to treat analysis. They were about 73 years old. The control group was, this was cool, the control group was 11 healthy, quote unquote, age-matched couch potatoes who did not have CHF, but sat on their ass and ate Cheetos and watched TV all day. So they also had very, very poor exercise tolerance. Same age, weak, useless geezers, but without heart failure. That was their control group.
Healthy means in the absence of this pathology.
Healthy means something that we were not able to bill for yet. Right? No disease that we could bill for yet. And then they did pre-testing, body comp by DEXA. They did echo. By echo, I mean an echocardiogram where they actually looked at their cardiac function with ultrasound. They measured their VO2 peak. I bet that was fun. They measured this physical fitness performance 10 scale, right? So instead of just walking, it was I'm going to go over it in a moment, a bunch of activities of daily living. And the self-report quality of life, I never believed those. That's like the RPE. Right? I don't believe that. And here's the PFP-10, transfer a weighted pot, put on and take off a jacket. People with CHF get tired doing this stuff. That's how shitty a disease it is, right? Pick up 4 scarves from the floor. Max overhead reach. Unload a washing machine and dryer. You know, I'm surprised they didn't kill anybody with that. Load a washing machine and dryer. Sit down on the floor and then stand up. Carry groceries and walk for 6 minutes and measure the distance. This scale has been validated in other studies. It measures broad domains, right, of upper body strength, lower body strength, balance and coordination, flexibility, and endurance, independent of VO2. The training program was the usual silly machine-based stuff right there. They did curls, for crying out loud. They did lat pull-downs, machine lower body stuff. They progressed to 8x3 at 80% 1 rep max for 18 weeks. It was progressive, so the 1 rep max increased over the training interval. And that's a nice long training interval for an exercise science study, so that's good. Here's the results. So, the most relevant results. So they looked at the left ventricular end diastolic volume, the stroke volume, and the ejection fraction. So these are the hemodynamic parameters, right? And here's what they found. In the control, they only did the pre-test. They didn't do an intervention, so they didn't see what they look like at the end of the study. Left ventricular end diastolic volume about 87 mLs, stroke volume 52, ejection fraction pretty good at 62%, right? The CHFers, look at the end diastolic volume, huge. Look at the stroke volume, wimpy. Look at the ejection fraction, a little more than half of the quote-unquote healthy control subjects. That is CHF. What do you think they got for the post values? What do you think? Anybody? No. They did not have an impact on the disease itself. And they didn't really expect to. So they did not change the hemodynamics of these people. What about their VO2 peak? Controls, about 23.4 mLs per kg per minute, pre and post. Why they bothered with a post measurement, I don't know. That is a shitty ass VO2 peak. That is really, really horrible. And what happened to it? Nothing. They did not improve the VO2 peak with a resistance training program. They did not increase their ability to take up and use oxygen. What about their 1 rep max? Well, everybody got stronger, as you can see, including the CHFers. They did in fact get stronger. And what about their physical fitness or physical function performance 10 scale? Yeah, everybody increased it over their baseline.
Even with bad exercise.
Independent of the effect on their hemodynamics or their VO2 peak. That is the take-home point. You can make people stronger, not really have much of an impact on their heart disease, not really have much of an impact on their VO2 peak, their aerobic capacity, and still improve their physical performance. That's the take-home point here. Their balance and endurance also, their balance improved. They say the endurance didn't improve. They say it wasn't statistically significant, but look at the trend. And the CHFers did better on this than the controls. So I don't know. I think that would be significant to me if I had heart failure. And their 6-minute walk, you know, doesn't look like a lot, but that's a significant improvement in performance for those people. What are the conclusions? The impairment of activities of daily living in CHF patients due to decreased strength is due to decreased strength at least as much, if not more so, than due to their aerobic capacity. You have to look at their discussion in the confounding of VO2 peak and muscle function. There's increasing realization that VO2, your oxygen uptake, is at least as much a function of your muscle uptake as of your cardiovascular function. That's a complex issue. I don't want to get into it. Improvements in strength are possible in CHF patients. They didn't kill anybody. And they produce concomitant improvements in actual activities of daily living and their actual ability to function independent of any change in their aerobic capacity or their actual cardiac performance. There are multiple etiologies of CHF. So there's a broad spectrum of etiologies. For example, any one of us could get CHF if we got a bad viral infection when we developed the viral myocarditis, right? So you can get it from a viral infection. You can get it from repeated heart attacks, what we call ischemic heart disease, that damages enough of the cardiac muscle that it can't pump well anymore. The most common cause in my population is hypertensive heart disease, right? So think of somebody who has to squat 500 pounds every day, year after year after year. Are they going to get stronger? No, right? They're going to get sick. It's basically an overtrained heart, right? That basically has this hypertensive load, hypertensive afterload that it has to meet, beat after beat, minute after minute, hour after hour, day after day, day after year, and eventually it starts to fail because it remodels and it gets stretched out and it gets bigger and eventually it starts to fail. Hypertensive heart disease is the really big one. Critical analysis, I thought the use of sedentary age match controls was excellent. The use of POOs, right, patient-oriented outcomes, excellent. Small and short, study populations had heterogeneity in CHF type and severity, so you're asking what caused it. Some of these people had ischemic heart disease, some of the people had hypertensive heart disease, right? So they had different stages of heart failure. So the study population was heterogeneous, not so good. No power analysis, and please note that both endurance and 6-minute walk showed strong trends to improvement despite little change in VO2 max. Aerobic capacity versus aerobic performance. Look for more on this in the future. So I think I've already given you the doggy bag. CHF is devastating. It's costly. A lot of people have it. You can train them. You can make them feel better. You can make them function better. You're not going to save their lives, and you're not going to cure the disease. We're going to finish up with a paper for Matt. Okay? Strength and overuse injury in military recruits, Hoffman et al., an older paper, right? Published in Military Medicine, 1999. These are the categories. Overuse injuries, especially lower extremity, are a major source of lost training time in military recruits. This study, they took a bunch of Israeli army recruits and sought to determine the relationship, if any, between pre-induction strength and fitness and the incidence of overuse injuries during training. Make sense? Here are the methods. They took 136 recruits, followed over 9 weeks of basic training. Prior training and recreation and sports were recorded. An activity score of 1 to 5 was assigned implicitly, right? No methodology for the score assignment. They tested their leg press 1 rep max. Aerobic testing was 2,000 meter one time. All Grabastic Maggot recruits had free access to the infirmary. And all visits were recorded to determine injury rates. Yeah, free access to the infirmary. Do you believe that, Matt? I don't believe it either. If presentation suggested stress fracture, pukey scumbag recruits were given a radioactive technetium. This is the Middle East. Life is cheap. And a bone scan and images were graded. Again, no explicit methodology for that, for the grading of the bone scans. They did the bone scans to detect an overuse injury, like a stress fracture, something like that. Make sense? Okay. Here are the results. They took 58 of these guys presented with complaints indicating a possible overuse injury. 12 of these were diagnosed with a stress fracture on technetium scan of the lower extremity. Poor aerobic fitness was not associated with the stress fracture injury rate. None of the guys who had previous competitive experience or a highly active background presented with a stress fracture. Pre-induction low activity levels were associated with an increased incidence of stress fracture. So in other words, if you were a couch potato before induction, you had an increased incidence of stress fracture. There's a problem there. We'll see if anybody picks up on it. Recruits who are 1 standard deviation or more below the population mean in absolute and relative strength were 5 times more likely to suffer stress fracture than stronger recruits. So there was an association between strength, not between aerobic fitness, but between strength and the incidence of overuse injury during recruit training. What's the problem here? How is it? I don't get this, and the authors don't explain it. How is it that if you had a low activity level, you had an association with stress fractures, but if you had poor aerobic fitness, you didn't? Can somebody explain to me how that works? I don't get that. It's a little hinky. But there it is. The conclusions: military recruits with greater lower body strength appear to be at lower risk for stress fractures of the lower extremity during military training. The authors hypothesize that this is due to increased bone mineral density and in those with greater strength or athletic training. This hypothesis was not addressed by the data. That's not what the study was designed for. It was not, in other words, it wasn't an interventional study. They just looked. The authors recommend that future research should consider examining whether strength training during military training can reduce injury rates. This is 1999, mind you. The study indicates correlation, but not causation. It was observational, not interventional. There are no mechanistic conclusions that can be drawn from the study. There was no sample size analysis, meaning no power analysis. Prior activity levels were self-reported and implicitly scored. Yes, sir, I was very active in civilian life, sir. So how much will we just take from that? I don't know. No explicit methodology for scoring of either the activity level or the bone scans, and the results so far as they go may be reasonably extrapolated to other sport and professional training scenarios and are important hypothesis generators for future research. But hey, what's the hurry? And it's only published in 1999. Has there been a lot of follow-up literature? No. So again, this is one of those where it's kind of like, you know, among the best papers we have out there and not that great. This picture was taken during the Carter administration. Yours truly. Anything else? Can we stop there? Yeah. Okay, had enough? All right, good. Thank you.